This meeting is now being recorded.
Good afternoon and welcome to the third webinar in a series by Dr. Georgi Kroupin. We're going to go ahead and get started, and I just want to let everyone on the line know that your phone is muted, but if you have questions during the presentation, go ahead and enter them in the public chat, and if we have time at the end or even if we notice during, we will try to answer any questions that come up. So I would like to welcome and introduce Dr. Georgi Kroupin. Thank you.
Thank you and good afternoon. Yes, I really much appreciate questions, so I would like to have this as interactive as possible, of course, given some time constraints. Today we'll talk about resistance and non-compliance in care for refugees. And everybody knows how important the topic is. We struggle with it every day and do whatever we can. In this presentation, I will argue that to improve compliance, most important thing is to build a partnership with our patients. And building partnership means helping them to have more agency, more say in what they do for their health care, which inevitably results in us losing some of our power, because partnership is about equal investment. But I think it's essential, and we need to understand that and need to learn how to live with it. So to start with, we will proceed with some definitions. Compliance is defined as the degree to which a patient correctly follows medical advice. Most commonly refers to medication compliance, but also applies to therapies and other recommendations. Adherence is the preferred term for World Health Organization. And compliance is often confused with concordance, which is a negotiated decision about patient's care, which results in compliance. Well, of course, for those who know statistics, it's a huge problem worldwide. World Health Organization data shows that only about 50% of patients are compliant in developed countries. And when it comes to preventive therapies, only about 28%, which is, you think of it, horrible. Out of 100% effort we both put, ourselves and patients put into this process, only 50 or 28% effect. Especially important with chronic illnesses such as asthma, diabetes, hypertension, and it results in the biggest financial burden in healthcare. Even though we have these numbers, it's often considered that these numbers and the compliance in the studies is overestimated compared to actual thing we have in clinic, because this is not from a so-called real-world setting. It's artificial studies with selected patients and selected clinics. So things may be even worse. Numbers for U.S. Annually, non-compliance can cost us up to almost $300 billion in emergency room visits and other avoidable expenses. It's been shown that it causes almost 125,000 deaths in the U.S. annually. 23% of nursing visits can be avoided, which is about $30 billion, and 10% of hospital admissions, another 15. We're talking about enormous amounts of money, effort put into this. Annually, non-adherence, about $2,000 per patient in physician visits, and everything expected to increase because of burden of increase of chronic diseases. Data from the National Association of Chain of Drugstores says that out of only 100% prescriptions given to patients, we're talking about paper prescriptions, obviously, only from 50 to 70 are taken to the pharmacy. 48 to 66% medications taken, that were ordered. Only 25 to 30 of those are taken properly, and only 15 to 20% are refilled as prescribed. Come think of it, it's a scary statistic, isn't it? I mean, out of 100 prescriptions, only 15 to 20 is taken as prescribed. Different illnesses such as diabetes, low compliance is the principal cause of complications for diabetes. With patients who take at least one medication, 1/3 is non-compliant, and patients who take 2 medications or more, only 13% comply fully, results in probably about 2.5 times increase in the risk of hospitalization for patients with diabetes. Scary numbers, all of them. Hypertension, low compliance is the main cause of uncontrolled hypertension-associated heart attack and stroke. Only 50% of people are at least 80% compliant. It results in 5.4 times increase of risk of hospitalization, rehospitalization, premature death, patients with blood pressure. Asthma, low compliance worldwide. Mental health is one of the major reasons for patients being non-compliant in the United Kingdom. Sorry, I need to remove that. Non-adherent schizophrenic patients 3 times more likely to relapse, and only about half of mentally ill patients take their medications infrequently or not at all. Less than 27% depressed patients adhere to their medication. We have to say that providers are not perfect either when it comes to compliance. Adherence was at 77% for short-term and 84% for long-term medications among doctors and nurses. Well, what do we expect from patients if we don't do it ourselves? Number of factors that are predictive of non-adherence and non-compliance: low literacy, homelessness, psychiatric disease, lower cognitive ability, complexity of medication, etc., etc. So, of course, this is a huge problem, and many people studied it, and there's different sort of approaches to improve compliance. The World Health Organization built a model that looks at 5 different areas where compliance is affected, including health systems, socioeconomic factors, therapy, patient-related factors, and condition-related factors. Number of models of analyzing and developing interventions was introduced, and one of them is so-called SIMPLE model, which addresses simplifying regimens, increasing knowledge, and working with patients' beliefs, and improving communication, removing the bias, and evaluating adherence. For those who are interested to look into this a little bit more in detail, there's reference to that. But we obviously can't cover even, 1/5 of what has been studied and offered. So we'll focus on some factors that we at the Center for International Health see most frequently in our clinical practice. And because we're talking about immigrants and refugees, I think starting with cultural factors would be appropriate. Several things that we can look at are definitions of norm and pathology, explanatory models of disease, approach to Western medicine in our patients, and patient-provider relationship and decision-making patterns. Definitions of norm and pathology. One of the things that we see is significant cultural differences by country in how people think of norm, what's normal. In most countries our patients come from, life expectancy is significantly lower than in the U.S. Even in Russia, several years ago, life expectancy for men was, if I'm not mistaken, 53 years. You take Korean, you take Somalis, you take everybody else, I mean, in a way, when we see a 60-year-old current patient and we're providing care, we are stepping into uncharted territory. They don't know this life beyond 60 on the average, you know. They don't know how to live well, be active, and have hope and take care of yourself beyond that age. It's if existent, you know, you can rarely come across. Again, back in Russia, retirement age for women is 55 years old still. Retirement age for men is 60. So in many ways, when we expect our patients to take care of themselves in advanced age, we are pushing them to where they know nothing. This is non-existent. We're opening a whole new world. And it's not only that help is not available, it's that the life was organized in a way that a person of 60 who is physically incapable of doing things doesn't have much of a life in many cultures. They are limited to staying home and at best taking care of their grandkids. And most importantly and most frequently, it's the family who takes care of them. Life is over at 60. And we're trying to push it. And I think for patients to take some sort of an active role in that takes a huge mental shift. And we need to work on that. Another thing is normalized based on patients' experiences. In mental health, when we see patients with post-traumatic stress disorder, say, normalizing is a huge survival skill. When people normalize their experiences, like I work with Vietnamese men who are survivors of re-education camps, this is a survival tactic for them. But once people think their symptoms and their condition is normal, even when help is available, it prevents them from seeking help. They don't believe that things can be different. They don't believe change is possible, and they don't even look for help when help is available. And I think it's a huge factor where we can make a difference. Explanatory models of disease. Well, we all know that depending on patients' cultural and religious beliefs, they have different explanations for both origins of disease and how you can get help with that. You can frequently hear our Muslim patients say that it's God's will, God brought it on me, and only God can take it away. That is again a survival skill because faith is a very valuable asset into surviving in different situations. At the same time, it may prevent people from seeking help. Monk people believe, some of monk patients believe in losing their souls and for that reason getting sick. I had a monk patient who thought that he got sick because he lost his soul, and I asked him, so if you were back home, how would you get treatment for that? He said, well, I would go see a shaman. And I say, well, why are you here? Why are you seeing me not going to see a shaman? He says, well, to see a shaman, I need to slaughter a pig. I don't have money, and insurance is free, so I'm seeing you for now. I'll take that, but a lot of the time, if we don't work with beliefs and faith, we don't understand patients' motivation and their sort of a take on how their problems came about. I think we need to incorporate that in our practice and work with it closely. Approach to Western medicine. First of all, in many cultures who were not getting health care in their countries, there's little understanding of how medicine works. In most cases, a lot of the time, people expect medications to work quick. At the same time, people are not comfortable with the concept of a long-term treatment. To think that you will be taking some medication for the rest of your life makes people very uncomfortable for different reasons. First of all, they are scared that they'll get addicted or dependent on medication. And on the other hand, most cultures and most countries our patients are coming from are so unstable and so sort of lower on the socioeconomic, economic level, that to believe that something will be there for you for the rest of your life is absurd. People, striving to stay alive and to sort of understand that, or sort of believe that some medication, some other things, supplies will be there for you for the rest of your life takes a huge sort of a paradigm shift. Of course, working with preventive approaches is a huge problem. This is an unknown concept in most cultures we work with. Attitude towards some of the things people experience as part of treatment, not only medication, say in physical therapy, is different. We all live in a culture where exercise is good, and certainly if you get some muscle soreness or you get tired, that's also a sign that you're working out, that you're improving your health. In most cultures where exercise is not a concept, getting tired is bad. It's not an advantage. Getting sore and tired, people are working so hard and their life is so physical that they avoid getting tired. Getting tired or getting sore is not a good thing. Health decisions, again, most cultures we work with are family-based cultures, and especially important decisions are not made by individual patients. An example would be sort of trying to hospitalize the patient with psychosis. We had several patients who needed to be hospitalized because they were dangerous to themselves or others. But right away, a lot of family members got involved. We had a case where Dr. Field, who was a psychiatrist in our clinic, and I worked with a Somali patient who was actively psychotic and suicidal, but his brother came all the way from Vancouver, left his business just to stay with his brother, and was present in all of his appointments. And so at some point when the patient became dangerous, there was a very intense conversation because the family was very much against him being hospitalized, and for a good reason, because if he doesn't speak English and he is put in the mental health hospital, it would drive him even more crazy. He'd be even more stressed. He finds himself in an unfamiliar environment, and symptoms may actually get worse. But at the same time, family has a lot of say in how patients are taken care of, because when the hospital stay ends, he will go back to the family, and they will end up taking responsibility. So we ended up negotiating with the patient's brother and the rest of his family, who promised us that they will watch him for 24/7 and be responsible for safety. And so we basically provided him with necessary medications and let him go home, which was a huge risk, actually, on our part, because we're most important, psychiatrist is liable for that decision. But it worked out fine. But that's exactly a compromise that I'm talking about, where we experienced lots of power on our part, but in the end, we achieve a better outcome because we include the whole system and we work with the whole system as it is. Patient-provider relationship is, of course, the most important factor of all, and we will talk about that more in detail. Many studies show that patient-provider relationship is central to success in both mental health and medical appointments. Odds of patient adherence are 2.26 times higher if a physician communicates well and has a good relationship, and more than 183 million medical visits that need not to take place will be avoided if there's a good relationship. Of course, talking about patient-provider relationship is a huge topic, and there's multiple areas. So we'll cover some of them, which I think applies both to mental health and medical appointments. First of all, every relationship in the clinic involves power and control dynamics, which I want to address. Power and control dynamics in families was the topic of my dissertation, and that was a sort of a model developed by my former advisor, James Maddox, who defined power as the ability to influence, and the control is ability to stop, negate, or deny influence. So he says that every relationship in the family, in the clinic, anywhere you have a meaningful, committed relationship, you have to address power control issues. What are different ways of exercising power? In social science literature, they identify several ways of exercising power, and I want to pay attention to three of them that I think apply more to medical appointments: coercive power, expert power, and referent power. Coercive is just scaring people or using other means to get them to do what we want them to do. Expert, showing that we know what we're doing and people should trust us. And referent is using information, educating our patients to do the right thing. Let's see how it works in the clinic. So let's take a look at three studies that analyze these factors. One of them was a study of 7,000 American women over 50 in a large American corporation, and the study looked at the frequency or the percentage with which women get their mammography, annual mammography exam, based on their coworker who is in some proximity to them was diagnosed with breast cancer. And they found when a coworker who they knew was diagnosed with breast cancer, the probability of mammography in the next year dropped about 8% from 70%. And this drop lasted for 2 years. And it was valid if the breast cancer case they learned about was advanced, non-early stages. This effect is known as information aversion. People know what's best for them. People know what they should do. But although they know and they're scared, they actually avoid doing things that would be useful. Another study is a study of college students to test them for HSV1 or HSV2 herpes simplex viruses. A group of volunteers got their blood drawn. Everybody got their blood drawn. And they were told that if they want, their blood will be tested for those two viruses. If they don't want, if they refuse blood tested, they will have to pay $10 to just pour their blood into the sink. And surprisingly, a number of people chose to do that, and while only 5% avoided testing for HSV1, 3 times that much paid $10 not to know what's going on with them, to avoid stress, fear. Well, of course, the significant factor here is that it's not treatable. It's a condition that will stay with you. So it kind of defeats the agency, the ability of a patient to do something about it. I mean, you can manage, but still. So this is lack of agency and lack of specific plan is a big thing in situations like that. Another study looked at a group of students who were educated about the risk of tetanus and who were offered shots for tetanus. So that 2 conditions were applied. One is there was one part of this group was given booklets with kind of a low fear arousing information, not so scary, and the other part was given very sort of a descriptive, very scary information about the risks of tetanus and consequences. Also, groups were divided by how specific the instructions were given to them, where they can give tetanus shots, and what happens after they get the tetanus shots. The result of this was that the high fear group although they definitely registered high anxiety, they were scared and sort of seemed to be motivated, and they were intending to do the shots, but they didn't. Inside this group, only the subgroup that was given very specific instructions where they should go, how they should do it, what's going to happen, and what's the risk and benefits of it, they were more prone to follow through and receive treatment. So I guess the sort of a take from that is that scaring people and just providing them information about how bad it is and what's the risk of it is not enough. Just information and just the emotional component is not enough. We need to have some kind of a mutual plan. We need to have cooperation, partnership for things to happen, for people to follow through. We need to activate their agency, their ability to do something, to have a plan, to have control over what happens and follow through. And that's what we're going to talk about further. Just to go back on, if we don't change this power dynamic from us being powerful and patients being sort of a less powerful, that's what we get in clinical practice. Typical reactions to power are either flight, run away, pretend dead, or go crazy. That's, you take it from animal kingdom, and we do it all the time. In clinical practice, flight is a no-show rate. If patients are not agreeing with what we do, they can't argue with us, for whatever reason, they don't feel enough powerful, or they don't have the language or whatnot, they just no-show, and we deal with it all the time. Another reaction is, I don't understand. People just block it. They don't try to understand what happens. Then don't try to be active in this encounter. Being crazy is pushing every button you can reach. You take medication, you drop it, you ask your neighbor for medication. So random, non-systematic reactions to danger, which is also no good. The only way to change it is, again, to build a partnership, negotiate the rules, and have a common plan to address the issue. Let's move on and see what we can do about building partnerships. In family therapy and in therapy in general, meta-studies showed that 85% of success in therapy is attributed to non-specific factors, which is building rapport. Although different schools and approaches claim to be more or less effective, only 15% of that attributes to a specific school. In medical family therapy literature, two factors are identified in building a good relationship and making healthcare effective. It's agency and communion, where communion is defined as as providers, our competence in what we do and care for the patient. And agency is the patient's involvement and commitment to his or her own health care. The same concept applies, more specifically was developed in family therapy by Carl Whitaker, who identified two most important factors for therapy to work. It's battle for structure and battle for initiative. Battle for structure is showing that we're capable, that patients can trust us with their problems. One of his books is called Constructing a Family Crucible. The idea is that we as therapists or we as providers need to be more resistant to stress, temperature, and sort of difficulty than our patients are for us to help them. And we need to demonstrate that we're capable of taking care of them. The most important factor is battle for initiative. In the end, therapy, and I believe any care, works only if patients invest in their care more than we do. This is the only way it works, and everybody knows that. If we can get the patient to get invested in their care, it becomes draining, we burn out, and most importantly, it's ineffective. It doesn't work. Everybody who works with people knows that, not only in healthcare. The good news is that looking for agency, we need to remember, and I came to believe it 100%, that agency is always there. But The thing is that it has many forms. It has many manifestations. I mentioned it in the previous webinar. I think what keeps me sort of going and energized is that I truly believe that everything people do makes sense, even when they're non-compliant, even when they're resistant, even when they use sort of unhealthy behaviors, whatnot. Everything makes sense. They do it for a reason. There are other considerations that are involved, and we need to see that and understand that. And then it changes the perspective of how we work with people and build partnerships with them. Obviously, working on compliance is the responsibility of both us and them. It's about building a relationship. They need to believe what's offered. They need to agree with the instructions or sort of prescriptions. And to do that, a lot of the time we need to understand and work with patients' belief system and with finding a way inside this belief system, whether it's cultural, religious, just comes from experience or their sort of particular life circumstances. And most importantly, this takes time, effort, knowledge, and practice. This is the stuff that takes a lot of time. And I think this is one of the barriers that we're dealing with because providers are under a lot of pressure. Not only providers, anybody who works with patients are under a lot of pressure. Financial, time-wise, the amount of stuff that doctors need to accomplish in their 20 or at best 30-minute appointment is incredible. And so I had a very interesting conversation. I used to be a part of the group that is called Collaborative Family Healthcare Association. It's based in Minnesota. It united physicians, social workers, psychologists, people from different fields working with patients and trying to collaborate to see patient as a whole person and try to do something about that. So there was a lot of talk about effective methods of group methods or this methods or involving patients and this and that. But there was an old Jewish doctor who everybody respected who had a very successful practice in St. Louis Park at the time. And after much discussion about those effective methods, they turned to him and said, well, we all know that you are a very effective doctor. Tell us, how did you do that? And he says, I saw fewer patients, I took more time, and I earned less money. Somehow, this response didn't go very well with the group, and they turned around and started discussing group methods again. So, but I think some of the time this is the only issue, and I think that's another way of looking at what we do for people. Talking about how we can build patients' agency and get them to be a partner, let's look at some of the basic sort of frameworks people offered to do that. Martin Buber was a philosopher in the late 19th, early 20th century who said that everything we do is just fight for being, fight for survival. Another psychologist, whose name is Paul Tillich, offered a more sort of a detailed analysis of that, and he said that we fight for being in three different dimensions: physical, spiritual, and moral. Physical, whatever we do is either making us stronger, enhances our physical being, or reduces it. In space, in physical capacity, if we get sick, we're dying a little bit. It's like, basically life and death thing, but we are dying every day a little bit in different ways. When we give up things we do, when we get older, when we can't do things, when we have to take medication and it has side effects, when we are limited in the capacity of connecting with people, it's all death is advancing on us. The only way we can deal with it, we need to do things that make us more stronger and sort of capable of dealing with that. Spiritual, we all fight for meaning. We will all need to feel that our life makes sense. And moral, it's sort of trying to look back and say, well, it was worth it. I did what I had to do. I'm a good person. And all of those three dimensions are interrelated. We'll talk about it a little bit more in detail, how it affects our lives every day. The thing is that, and I think that's one of my favorite things about working at the Center for International Health, is that we're talking about some dramatic things that are applied to immigrants and refugees, but actually we do it every day. It happens to us. We're losing things every day. We're losing people. We're making choices. We're getting older. We're getting sick. We struggle with meaning of life. We look at us and think, was it worth it? Are we a good person? So it's just that working with our patients is more extreme. It's more in your face. You can't deny it. You always deal with sort of a human tragedy, human drama, and sort of extreme situations where you need to survive and make sense of things. Refugees deal with all these three things every day, and it's pretty obvious for everybody who works for them. And they can get in conflict between all those different dimensions. What kind of problems with adherence happen if we have a crisis in physical dimension? Well, first of all, as we talked about it before, fear of being dependent on medication. This limits your being. You become less of a person if you agree that you can't live your life without medication. And especially for those people who are not used to the concept that life is better with chemistry, it's not. It's not what they want to do. Dealing with side effects. I mean, everybody knows how limiting medication regimen can be, or dealing with diet restrictions, or dealing with this or that. Again, it limits your life space. It limits what you can do or who you can be as a person. Same goes with addictions. Addictions, we talked about it in previous seminars, are hard to fight because they offer so much. We talked, I think I have an example later. One of the behaviors that helps you to control anxiety and emotional and physical condition, helps you to focus, concentrate, helps you to structure your life, helps you to connect with other people, helps you to sort of introduce some meaning, so expecting something good that happens in your life. Smoking can do that. When you smoke, you calm down. When you smoke, you sort of stop. You stop paying attention to other things. You focus a little bit. You kind of change your breathing. You have some sort of a social bubble when you smoke. I can stop thinking about something, other things for 5 minutes, et cetera, et cetera. Addictions or, behaviors, unhealthy behaviors like that, they have a lot of benefit to offer in other dimensions, in social and structuring your life and being more in control. And I think, yes, in some ways it's chemical, but most importantly, it's psychological and social. It changes, it gives you the tools that you don't have in life. So if you remove that, if you're required to go on diet, drop, and stop smoking, this or that, you give up some of your life. You restrict you die a little bit. I think that originally this presentation started with conversations in the clinic. One of our providers referred me a patient who he thought should give up smoking, but after much conversation, patient says that this is the only joy I have in life. Nothing else. My kids live, 50 miles away. I see them at best once a month. I don't have friends. I don't speak English. I don't drive. He lives in a building right across the street from our clinic, and I see him actually going outside smoking every day. This is his thing. The only thing that he thinks he has left in life. You can't take it away. I mean, and any long-term benefits of that don't compensate for what he's going to lose. Emptiness. As we talked about, everybody strives for life to be meaningful. If you go on dialysis, it does a lot. It takes a lot from your life. You can't go places. You become very dependent. You can't do things you need to do. Another patient of ours wasn't going on an insulin shot because he thought it wasn't a macho thing. He said men shouldn't do that to themselves. I mean, his idea was to keep his manhood as he understood it. Our understanding of what kind of a quality of life or what meaning of life we have a lot of effect on what we agree to do or don't agree to do, and we need to have conversations about that. If we don't open this issue, nothing's going to happen. People will just go away. Very frequently, for those who work with immigrants and refugees who experienced a lot of trauma, you hear things like, I can't think about myself. I can't do that until I take care of my kids. Or if I lost my kids, or if I wasn't able to take care of my loved ones, I'm not a person who needs to be taken care of. I don't deserve it. I failed myself. Same goes when people don't have hope for the future. And that's, I think, one of the biggest things for me personally in the clinic, because this is the most depressing and the most difficult thing to work with. When you have a patient and you ask them, what are you hoping for? What are you looking for? And they say, nothing. I'm just waiting to die. And you hear it quite frequently if you dare to venture in this sort of area. And that's a killer, because if I don't have energy coming from the patient, they don't have hope, there's not much we can do. I think that's exactly why I'm doing this, and I'm thinking about these things, to try to help the patient to move from where he doesn't care about his life, where he can say, I want to live, I want something. We talked about loss in previous webinars, and I think the important thing here is to acknowledge the loss and limitations and the damage that people experience in their lives, and not to try to pretend that we're going to fix it. We're not. We're not going to fix it. If we do that, if we pretend, they know we're lying and nothing's going to happen. It's about accepting what happened and still finding some strength and some hope for the future to live with what happened and maybe have some good in this life, balancing this loss and some hope that should be there for the future. So when people try to cope with those problems, they use different strategies, as we discussed it before. And some of those strategies could be problem behaviors and could come through as resistance or bad habits. Well, to another illustration of how it works is, say, major depression. If you don't think of it as chemical imbalance, or if you think of major depression in sort of existential terms, this is what it is. I've tried everything I could. I failed. I can't get hurt anymore by trying, and I give up. I think for me, this is depression in a nutshell. It's when people fight, when people get hurt by fighting, when they don't have enough resources, strength, they stop fighting. Depression can be defined as reduced vitality. It's just what happens is a person, when they can't handle the full spectrum of life, they reduce their life space to some manageable size where they can reasonably feel safe and they can have influence, and it gets smaller and smaller. When you talk about helplessness, it's just a way of saying that I don't have to keep trying anymore, I'm done. Or hopelessness, no, not in the future. So it's just making your life small, controllable, where you can somehow tolerate it. You lose a lot, but you avoid what they call in the social science literature catastrophic condition, where your life is out of control. This is the scariest thing ever. People can't live with it for a longer time. They always, by different means, they need to control their lives, either by making it smaller or by using other means that will help them to control it. And we need to understand that and appreciate that, and then see it as positive, as a coping strategy, not as a weakness or deficit, then we understand that we will be on the same page. You know, I was involved in a project of Jewish Family Service working with Russian elderly who are diagnosed with depression and discussing interventions with them. But then come think of it, if you have an older person who doesn't drive, doesn't speak English, can't go anywhere, feels sick, family is away, what if you all of a sudden, by a miracle, give this person all the power in the world and they became, you know, vivacious and energetic? What are they going to do with it? What exactly are they going to do with it? Because, so in that ways, in many ways, at least some part of being depressed is adaptive and helps people to avoid pains of trying. So if we focus on one dimension and we trying to reason with people, try to convince them to do what's medically or even physically appropriate, we risk defining their behavior, whatever it is, in negative terms, and then see it as not purposeful, and then see whatever they do as a sign of weakness. And then we're not using patient's agency, we're missing it, we start fighting it. If we define everything, if we look at their behavior as always purposeful, there's always some sense to it, then we see it as patient's strength, and then we cooperate and work with them together to achieve the results we both want to achieve. You know, there's a Zen sort of saying that everything pursued to the limit reveals Buddha nature. Means that whatever you do, just be consistent and go through, and you will still end up fighting same existential and bigger issues. And if you overcome them, you will find Buddha within yourself. The scary thing here is that if we accept that patients have a say in healthcare decisions and the way they do healthcare, we will have to accept what they say, and sometimes it won't go along with what we say. So we put, instead of being an expert and trying to make them do what they're supposed to do, we will have to compromise some of our power, and this is scary. This is pushing our vulnerability and our ability to deal with ambiguity and uncertainty. Like this example with hospitalizations of the somatic patient, that was scary. And then still, yeah, it looks like it was the right thing to do, but you never know. What if something happened? You know, then what? So I think that's the price that we pay. If we want to have a partner, then we will have a partner who makes their decisions. And then sometimes it won't be our decisions. And I think a lot of training, of course, definitely in medicine and in helping professionals, goes against it. It goes against, you know, taking too much risk or, you know, giving it to another person and negotiating things. And again, time pressure, legal pressure, all sorts of other things pushes us to be in charge, to be in control, to be responsible, which is a great thing. But at the same time, it's a double-edged sword. It limits our ability to be partners. And so I think that's the challenge is to work out this compromise and find the balance between this and that. With all that, how does it work for us in clinical practice? What do we do? It applies to mental health, but also to medicine, I think. First of all, working with immigrants and refugees in mental health, we work with a lot of trauma and with a lot of situations where patients don't have or didn't have control over their lives. And our first step, my first step when I work with patients is to try to give them this power, this control back. So that and it starts with physical. It starts with safety. I always give the patient an option to stop the session, to keep the door open, to walk out, to not to talk about things, they don't want to talk about, et cetera, et cetera. There's nothing I must do unless it becomes sort of physically or emotionally dangerous, and then I shift into being an agent of social control. I just need to take care of things. But that's not therapy. That's not partnership. I'm just doing what I need to do. I think next step is advancing or furthering this kind of a partnership by, I always say when I start discussing difficult issues with patients that my job is to ask questions. Your job is to take care of yourself. I don't know you yet. I don't know what's difficult for you, so I rely on you to tell me where to stop. So if you don't want to talk about certain things or you feel it's too much, please let me know. And I try to enforce it every session. I think it applies not only for mental health, but also could apply for medicine. I mean, a lot of people who've been through trauma, abuse, and this and that may feel very uncomfortable with different types of procedures, exams, and I think it's important to keep these options open. There are some things we have to do, but there are other situations where we can definitely negotiate things, and that will increase our ability through safety and through partnership to work with people. For me, when I work in mental health, it's really important to give the patient the ownership of the problem, increasing his age. He will need to tell me what the problem is. So we've been working on screening, mental health screening in our clinic and with the Minnesota Department of Health. So we developed a screening tool, and one of the most important parts of this screening tool is ask the patient, do you think you feel sad or worried too much? This too much part shifts the definition of the problem to the patient by saying everybody worries. Everybody feels sad. And with their life, with their problems, of course they feel sad and worried every day. They need to say that they worry too much, more than they expect. Then they accept the problem. Then they say, yes, I have a problem. I need help. That's the first step into moving into working together. They have ownership of the problem. And you can do it in different ways. In medicine, of course, because every patient, except, again, life-threatening situations, every patient defines what kind of a quality of life and what kind of a health they want to have. And it's a lot of the time it's open for negotiation. This is somewhat specific, I think, to mental health, where, first of all, and that's a topic for a whole different webinar, which we may do next month about working with interpreters and working with language, but it's very important. We have sort of discussed and pushed this issue in our clinic. Use lay language as much as possible, especially in mental health, if it's limiting in medicine. In mental health, every human condition can be described in normal human words. There's nothing in this life that cannot be described from person to person. We have normal words to say that. A lot of cultures don't have words for depression, anxiety, this, that, and the other thing. And patients don't understand that. I won't go into much details, but it's a really important issue. Instead of using diagnostic labels, use symptoms, especially when you refer people to another provider. For example, medical provider refers to mental health. Don't say you see him because you're depressed, you're anxious. Say you're not sleeping well, you worry too much, you don't remember things, you can't concentrate. And this person will help you to do that. Then first of all, it's not stigmatizing, normalizing. Everybody does that. And then it's really specific to behavior, and it's not sort of labeling the patient as a person. I think it's really important to know the limits of your competence. In mental health, for example, we talk a lot about cultural competence. I think for me, number one cultural competence thing is to know that I'm ignorant about a lot of things. I work with 30 and maybe 40 different cultures. There's no way in the world I could know enough about even one of them to be sufficiently culturally competent. But even with that, I think a lot of the time I'm a worse therapist with Russian-speaking patients because I assume too much. I think, yeah, I know what you mean, but I don't. Every single person is unique, and they live their unique life, and it helps me much more. It makes me feel free when I say, I don't know much about your culture. Tell me about it. Don't know much about your religion. That liberates me and the patient, who then doesn't feel constraints of sort of a shared culture and what's appropriate, what's not appropriate. Positive reframing. Every single person who sits in my office is a survivor. And I think this is the most important thing about them. That gives us access to their agency. How did you do that? How did you survive and come to tell the tale? I think in that way, the name of a Center for Victims of Torture is very unfortunate. Fortunately, most patients don't understand what the name means, so they don't suffer the consequences. As I said before, every path leads in the right place if you're consistent. Everything is yes and. This is a principle in improvisational comedy, and I believe this should be a principle in our work. Everything makes sense. Everything happens for a reason. And so when you do this, what happens? Does it work for you? What else can you do? And that makes, again, a better partnership with people. Working on physical being, managing control, using people's resources, helping them to structure their lives and increasing competence. That makes them stronger, more powerful. Working with patients' ability to improve their spiritual being. Affirm that person is always doing their best. I totally believe that we all do 100% of what we can every moment of the day. And if we didn't know. We couldn't, we were not prepared, not trained, etc., etc. So guilt is sort of a surrogate attempt to regain control of the past. It's useless. Only forward. Moral being. I think, first of all, we need to show respect. And second, we need to know of who our patients, who they were in sort of a previous life. Instead of old and sick people, we will see teachers, we will see farmers, we will see military men, fathers, mothers, etc., who live very productive, very important lives, and we need to see them as such. Dealing with critical situations in the session, when something happens, when people have a panic attack or when people get too emotional, they've been there. If something happens in the office, it's almost for certain happened before. We need to use people's competency to deal with that. We ask them a question, when this happens, what do you do? And we find some answers, and then we offer some other things that they can use to cope with things. I think the very important question is to ask them, are you going to do that? Even if they understand what's important. The answer may be no, because they have other circumstances, and we need to be prepared to hear that. I think one of the pivotal things is shifting from coping to strengthening, and doing things that make you stronger, doing breathing exercises 3 times a day, not only when you feel bad, doing exercise every day. It's a critical shift in care. Shift to positive and hope for the future. And I think by doing that, we can achieve shifting people from where they don't want to live to a point where they start caring about themselves, and then eventually, hopefully, to a point where they can say, I want to live, I can manage what happens, and I have hope for some better things in the future. That will be that. Thank you. And that's some resources that you can look up. So I know we're just on time. We don't really have much time for questions, but if anybody wants to stick around and ask questions, I'd be very happy to answer them.
Wonderful. Thank you, Dr. Kroupin. We don't have time for questions online, but you could email questions maybe.
Sure.
But also know that you will be getting a survey, SurveyMonkey to answer, and please fill out the evaluation that's attached to that, and that is how you will get your continuing ed certificate if you are going to apply for hours for that. I just got a question that it asks if we can get a copy of the slides, and that would be fine. I will send that out along with the link to the evaluation results. So thank you very much. Look for information coming about the next webinar. Dr. Kroupin mentioned doing one on working with interpreters, and that will be the next topic that he will dive into. Thanks very much.
Well, if you have questions, or comments or whatever.